Hi, good afternoon. Welcome to the ERN-EuroNMD webinar that was organized in collaboration with the Rare Neurological Disorders ERN and the European Academy of Neurology. Today, we are going to have the pleasure of having with us Professor Olivier Scheidegger. Is from the Insel Hospital from Bern, the Bern University Hospital, and he runs the Center for Neuromuscular Diseases and the Department of Neurology. Olivier is a remarkable clinician and academic that has an impressive record in terms of his scientific knowledge and development. He is a neurologist, a neurophysiologist, and a neuroradiologist, and he has a particular interest in neuromuscular diseases, namely in imaging research and methodological developments. And so he's someone that we know very well at the Institut Neurology in Paris, and is also had some time training with Pierre Carvier, that is also a panelist today, and I also welcome and thanks. Is the member of the scientific panel for neuromuscular diseases of the European Academy of Neurology, the co-chair of the cross-cutting specialist group Neuromuscular Imaging of the European Reference Network for Neuromuscular Diseases, EURO-NMD, and a member of the TREAT-NMD Alliance. And since 2019 is the head of the EMG station and neuromuscular center at the University Clinic for Neurology in Bern. So thank you, Olivier, for giving us the pleasure and the opportunity of listening to you. I would pass on the mic to you, and please start sharing your slides and start whenever you can. Thank you.
Thank you, Antonio, for the kind introduction and the invitation to being able to give this webinar on MR neurography. So it's my pleasure to give an introduction to MR neurography today. So I have no disclosures relating to this topic. I will briefly give an introduction and a historical perspective on MR neurography, and then switch over to basics of methodology. And something that is quite interesting in MR neurography is also the quantitative aspects we have, and at the end show a couple of strengths and weaknesses of the technique, kind of as a wrap up. So if we look at the developments of MR neurography since the beginning of MR, with the prehistory of MR in the 1920s, and the first MR imaging then in the 1970s, we see that around the 1980s we have the first peripheral nerve descriptions in MR, which were actually the cranial nerves as a kind of, in quote, byproduct of cerebral imaging. But it's only in 1992 that the term MR neurography was introduced by Howe et al. And so the term MR neurography refers to tuning the sequences in such a way that we have a nice or a better contrast of the peripheral nerve and can image and visualize the peripheral nerves. So the first attempts is actually from the publication in 1992, where you see the higher signal of the upper arm nerve, which is also depicted by the arrows. So if we look at the publication, number of publications using the term MR-neurography since the beginning in 1992, we see that it's only from in the last 10 years that we have the whole bulk of publications and evidence that has come up. So it's a really a recent, actually a recent technique. And if we look at the different images that were acquired or published during this time, we see here in 2004, for instance, on the top right, a peripheral nerve tumor of a leg, and on the left side, we kind of barely see what it depicts, but it demonstrates the plexus, the brachial plexus, and the different nerve roots. So actually the images weren't that nice then, but a couple of years later, then when the sequences were kind of tuned to have a better morphological detail, also of the extremities and all the soft tissues, then the interest came up because the peripheral nerves could actually quite well be delineated using the MR. And you see here already that the peripheral nerves are much more visible. Here on the left, the brachial plexus, and on the right, the thigh. So it's about around 10 years ago that the term high resolution MR-neurography came up, and it was actually a term that was used to demonstrate or to tell that high resolution images were used to have a better appreciation of the structures of the peripheral nerves, as you can see here. And mostly the term high resolution MR-neurography was used for high field MR imaging, meaning at 3 Tesla, and then of course above. And already here you can see that in the sciatic nerve, you can, in some parts, depict already nerve vesicle bundles compared to the first images we saw from a couple of years ago. So if we look now at the evidence or the publications from the last 10 years, we clearly see kind of two different approaches that were taken. On one side, we have more kind of case descriptions of different pathologies using high-resolution MR-neurography. And on the other side, we also have different groups that have started
Olivier?
to have a more systematic approach to hello?
We had a cut, so perhaps I would ask you to repeat 2 phrases before. Okay.
You still hear me?
Now we hear you, but we had a cut of about 30 seconds at least. Okay,
sorry. So here we see the publication of the evidence in the last 10 years. We see kind of two different approaches that have been taken. On one side, we have more kind of case descriptions using MR-neurography or high-resolution MR-neurography. But on the other side, we have groups that have tried to have a more systematic approach to the disease phenotypes of peripheral nerve diseases using MR-neurography, and also looked at the more quantitative aspects of MR-neurography. So Now let's move to the basics of the methodology. This is something that is quite familiar. So we have the bulk magnetic fields, and we have then, of course, the MR physicist that tunes the scanner and adapts the sequence in such a way that we have an excitation, and then we can, depending on the acquisition parameters, we get images or signal from the tissues. So what we will see actually depends on one side, of course, of because depends on the MR physicist, but on the other side, of course, because of the tissue properties. And so the different tissue properties that we look at is, of course, the molecular structure. And here, as we use proton imaging, we will look at mainly water and also the protons in fat. We have also the water molecules that surround proteins and different structures in the peripheral nerves that will also interact with the water protons and change the signal behavior. And we have diffusion and flow that changes or can be used to look at the signal of protons in the tissues. And what is quite interesting also with diffusion is that in tissue we don't have a Gaussian diffusion, but we have a more restricted diffusion because of anatomical barriers. That's quite well known, of course, in cerebral imaging with the diffusion tensor imaging. So why is this also interesting for peripheral nerves? Because as you can imagine, or you know, that the structures of peripheral nerves depend on the pathology. For instance, here, if you look at electron microscopy of peripheral nerves, of axons, and you see that in healthy subjects, the myelin sheath is quite densely packed compared to, for instance, in patients with CIDP. And so you can imagine that, of course, the diffusion properties will also change in the peripheral nerves depending on the pathology. So next to the tissue properties that govern the signal in the peripheral nerves, it is also the acquisition sequence. And why is that important to remember? Is that, as you can see, depending on the signal that or the structure that will give the MR signal, we will have a decay of the signal with time that depends on the structure. For instance, you have quite fast T2 decay in fibrous tissue, and depending on how the acquisition parameters are set, especially the echo time in T2 images, you will have a kind of a snapshot of what structure will give you the signal. So it really depends on the exact image or acquisition parameters, on what signal intensity, and also then, of course, the sensitivity to the disease process you will have. So by choosing, for instance, a wrong acquisition parameters, you might not see slight or some disease processes in the peripheral nerves. So what sequences or sequence type are mostly used to look at the peripheral nerves are mostly T2 weighted and fat suppressed images, and also diffusion weighted images because of the aspects I just mentioned before. And to remember that the aminography and the image captures only a small facet of the underlying process. So because we still don't know too much of the imaging and the signal behavior of the different pathologies, because of the quite recent technique or use, or the expanding use of the aminography, we can we still don't really know which parameters we need to use for what type of disease. So this will also, of course, have an influence on how the different results are reported in the literature. But what is quite important and interesting is that all these processes can be assessed quantitatively. So if we look at the different etiologies that can affect the peripheral nerves, we know that the MR neurography is more a surrogate of the disease pathology, meaning that it can is quite sensitive to disease processes like axonopathy or neuronopathy or segmental demyelination, but is less it's less specific to a certain disease entity, meaning that, for instance, both hereditary neuropathies and, for instance, inflammatory neuropathies that come with hypertrophic or can come with hypertrophic nerves will have a similar signal behavior and morphologic appearance. So it's the MR neurography is quite a sensitive technique to the disease pathology, to the underlying disease process, but not very specific to at the moment to the different nerves, nerve pathology. So why is the bulk of evidence or publications only that recent in peripheral nerves? And this has also to do with the advancement of the technology. Because if we look at the different structures that can be imaged using aminography, we see that it highly depends on the resolution we use. So at 1.5 Tesla, as you see on the left, you can kind of nicely depict the peripheral nerve, but you don't see any special details within the nerves. But already at 3 Tesla, with a resolution down to 200 microns, you start to see structures or substructures of the peripheral nerves. Means that you start to see nerve vesicle bundles. And if you go to even ultra high field, you can then, of course, because of the more because you have access to more signal, you can even lower the resolution, and you can start to see structures within the nerve vesicle bundles, as you can, as is nicely depicted here. And then you start to go to the resolution of microscopy. So if we look at what type of sequences we want to use for aminography, we can both use 3D sequences and also 2D sequences. The 3D sequences have the possibility that you can reconstruct the anatomical region in any direction. And this might be quite helpful depending on the question that is asked by the clinicians. So, for instance, if a nerve surgeon wants to look at the three-dimensional aspect of a peripheral nerve tumor, then a 3D sequence might be quite interesting for him to look at the volumetric aspects and also the surrounding structures nearby. However, with 3D sequences, you have, of course, a low resolution, and these are also quite time-consuming. If you use 2D sequences, you have the ability to have much higher resolution, meaning that you can really go down to 200 micron, and you see depict substructures that we have discussed previously. But of course, because these are 2D sequences, you cannot do a nice reconstruction as with a 3D sequence. Also, these sequences are quite time-consuming. So, really, the main limiting aspect of MR neurography is the acquisition time, because the acquisition time is related to the resolution. And obviously, we want to have a high-resolution images to look at the peripheral nerves. So with 3D sequences, you also have the possibility, depending on the sequence type used, to have a nice overview of the peripheral nerves, as shown here, for instance, in the patients with nerve sheath tumor, peripheral nerve sheath tumor of the plexus on the left side, and on the right, the morphological aspect of a patient with a CIDP. And you can also use what is called the maximum intensity projection, which is kind of an intensifying the high intensity of the peripheral nerves in the images you look at, and you can use this technique to kind of have a nice overview on the pathology. However, you don't have the details. If you use 2D sequences, you really can see different nerve fascicle bundles, and also the alterations of single nerve fascicle bundles, quite similarly as you have with high resolution ultrasound. So if you want to use the MR neurography, then it is quite challenging to have the patient have the extremities scanned, depending also on the morbidity and the age of the patient. The lower extremities are quite, you can quite well use dedicated foot coils and knee coils, and these dedicated coils give you the possibility to use these high resolution sequences. However, if you use body matrix coils like you have on the left side, you have much less signal and coil sensitivity that give you less signal, and you can only use lower resolution sequences. But with the body matrix coils and the spine coils, of course, you can look at the nerves throughout the whole body. If you want to image the upper extremities, it is quite easy to use, of course, the hand coil. But if you want to look at the nerves in the arms and forearm and the upper arm, you can even use the knee coil, but then you need to position the patient in a prone position with the arm elevated. And as you can imagine, this is not feasible for all patients, depending on age and also on their condition. There are now dedicated surface coils, as depicted on the lower right, that have quite a good sensitivity and really can be also used to acquire high resolution sequences, especially of the upper extremities and the plexus. But these are not always readily available in all departments. So one of the big challenges is that you have to convince your radiologists to start doing such exams, because radiologists tend to have, if they're not trained in MR neurography, they tend to have a standard approach to image the extremities. So they are quite they're quite used to do protocols for articulations, for shoulder, for elbow, for wrists and hands, but they're not used to tailor their examination to neurologic questions. For instance, if you want to have a proximal to distal lesion localization in a patient having a sensory disturbance, for instance, of the ulnar part of the hand, and you're not sure, or the electrophysiological techniques don't give you clear localization if it is a C8, a lower plexus, or a ulnar nerve pathology. So to do this kind of examination, you need to have an imaging protocol that is tailored to this question. So really, as we know, the different neurological questions of peripheral nerve require quite a flexible access or just as if you do the electrophysiological exams tailored to the question you want, you also need to do that with the MR neurography to have really at the end the question solved you asked for. So it's really, you need to talk to your radiologist and do the exam with him. You need to use also the correct sequence type. The most important sequences are the T2 weighted fat suppressed images, as we have already seen many images. And what is also quite helpful is to have a correct angulation to the nerve trajectory. So we need to angulate the sequence so that they are perpendicular to the nerve trajectory, so that you can also assess the different nerve fascicles. Of course, some groups prefer more the 3D, 2D sequences, which is also possible. But still, if you want to look at the fascicular pattern, you really need to adapt the sequence according to the nerve trajectory. So the different nerve aspects or pathological nerve aspects you can have in the T2 sequences. You have this granular polyfascicular pattern in the normal nerve. You can have tumefactive lesions. You can have focal lesions where you have the signal intensity with or without morphological changes, meaning cross-sectional area changes of the peripheral nerve just at the focal site, where the signal intensity and the rest of the morphology is normal, proximal and distal to the lesion. Or you can also have extended lesions that run from the plexus to the most distal parts of the nerve. What's quite helpful in the assessment is also that you expand the analysis not only to, or you don't restrict it to the peripheral nerve, but you expand it also to the whole motor unit, so that you can do kind of a pattern analysis of the secondary changes that might happen in the muscles or in the motor unit. So, for instance, you can clearly see a difference in the denervation, edema, and pattern. For instance, if you have a sole lesion of the peripheral nerve, peroneal nerve, or this looks quite differently if you have L5 radiculopathy. So, looking at the expands the analysis to the motor unit can be very helpful as well. And this comes actually for free because these are exactly the same sequences you use actually to image also the peripheral nerve. So these are also T2 weighted sequences. So in this nice study by the group in Heidelberg, where you see the different pattern that can happen if you look at the nerves and the muscles, you see that there are quite striking differences in motor neuron syndromes that have this that are in the differential diagnosis, for instance, in ALS or in multifocal motor neuropathy, compared also to the healthy subjects. So if we move now to the quantitative aspects of MR neurography, of course, we are quite familiar with the morphometry and the morphological aspects of the muscles, but we can actually use also these techniques to do morphometry of nerves, as you can see on the left side here from a sciatic nerve. So it can be interesting not only to look at the morphometry, but also at the signal intensity, which you can assess quantitatively using certain post-processing techniques, and these can give you complementary information. For instance, if you look at the top, you have the 3D rendering and the morphometry and the signal intensity along the proximal distal aspects of a sciatic nerve in a healthy subject, and you see that the cross-sectional area kind of remains more or less the same in this segment. If you look at the focal lesion on the lower left side, you clearly see that at certain parts the cross-section area is enlarged, which you can assess quantitatively, and also the signal intensity was changed in this part. However, you can also have some peripheral nerve lesions where you don't have any changes in the morphometry along the proximal distal axis, but you can have signal intensity changes along the nerve. So also these aspects can be assessed quantitatively using corresponding post-processing methods. And not only, it might be quite interesting to look at the nerve fascicles that have a bright signal within the peripheral nerve, but you can also look at kind of the missing nerve signal in the peripheral nerve, as has been nicely shown by Yende et al. Last year, where you have with in these patients without polyneuropathy on the left side and with moderate or severe polyneuropathy, you kind of have an augmentation of the kind of the missing nerve signal within the peripheral nerve. So also these aspects can be aspects of the morphology or signal behavior can be assessed quantitatively. It has also been shown that quantitative morphometric data can correlate to a functional impairment, especially in compression neuropathies. That has been shown nicely here in this study by Bäumer et al. For the ulnar nerve compression neuropathy, where they divided ulnar nerve entrapment in mild or severe, depending if there was atrophy and more severe motor deficit. And they could clearly show that there was a more enlarged nerve in the more severely affected, functionally severely affected patients. And as we all know, the inflammatory neuropathies, especially CIDP, can have enlarged proximal nerve segments, and you can, if you look at the functional or the morphometric data and correlate it to the electrophysiology, you can clearly see that you have correlation of the morphometric data with the electrophysiology. So meaning that you have with larger cross-sectional areas, lower conduction velocities, and lower compound muscle action potentials in these nerves. Not only the morphometric data can be interesting to assess quantitatively, but also the diffusion processes within the peripheral nerves. So this is quite nice. A preclinical study that was done in mice in 2009, where they used diffusion-based tractography and induced a crush injury in the sciatic nerve of the mouse and had a follow-up functionally in MR and histology. And they could clearly show that the diffusion, some diffusion matrices, especially the fractional anisotropy, correlated well with the terminal re-innervation. So that means that on the right side, you have the fractional anisotropy of the nerve proximal to the nerve injury at different time periods from before to after the crush injury. And you see that proximal of the nerve lesion, you didn't have any changes of the fractional anisotropy, but distal to the crush injury, you had a much lower fractional anisotropy, meaning that the diffusion process wasn't restricted too much anymore because of the loss of the myelin sheath and the nerve structures, and it's during the regeneration you had more and more the anisotropy that was increasing, and this correlated quite well also with the function of the leg. This has also been shown in, has also been shown in humans. For instance, in this prospective study in CIDP patient compared to matched controls, where they did a DTI in nerves of the upper and lower extremities. And the fractional anisotropy here also correlated to the electrophysiology, meaning that you had with higher fractional anisotropy a higher velocity in the neurophysiological studies. So normative data is now more and more also becoming available. So you have normative data for nerve caliber T2 relaxometry. You have normative data also age-dependent in for DTI-derived parameters, for magnetization transfer rates of peripheral nerves, and also of nerve caliber and DTI, also in children and adolescents. So coming to the last part of the presentation, I want to show a couple of strengths and weaknesses also of the technique. And what might be quite interesting is that, as shown by Morrow et al. In 2016, that not only looking at quantitative aspects of peripheral nerve, but also looking at the quantitative parameters of the muscle in neurogenic diseases, for instance, as they did here in CMT1A patients, they could clearly show a progression over 1 year of the fatty infiltration or the degeneration due to the nerve, progressing nerve pathology. So assessing quantitatively the muscles can also be helpful. Here, Colmer et al. Looked at the signal intensity changes in
Olivier?
Familial amyloid polyneuropathy.
Sorry
Yes.
to interrupt. We lost you through a few seconds. Can you restart this slide comment, please?
This slide comment here, yes, of course.
Okay.
So this study was done by Colmer et al., where they looked at the signal intensity changes in familial amyloid polyneuropathy in carriers and compared to patients having the overt disease, compared also to controls. And what they could show that the carriers that weren't that didn't have any symptoms had already lesions in the similar regions as they have seen in patients with overt disease. So what was quite interesting here to see is that you have quite a discrepancy between the structural changes you see in aminography and the function. A strength of aminography, especially if you use the high resolution 2D sequences, you can look at the somatotopic organization of the peripheral nerve, and this can give you hints on also on the etiology. For instance, if you look at compression neuropathy of radicular compression compressions of L5 or S1, patients with L5 or S1 compression syndrome, you clearly see that patients show different signal intensity signal intensity changes at different parts of the peripheral nerve, depending on the somatotopic organization of the nerve. For instance, you can see that the L5 fibers run more in the anterior aspects of the tibial part of the sciatic nerve and in the peroneal part, whereas the S1 are more localized in the dorsal part, especially of the tibial portion of the sciatic nerve. So it can also be helpful to look at which nerve fibers or what the somatotopic affection of the peripheral nerve is regarding to the etiology. Quantitative measurements can also be done at the subfascicular levels, as we have seen also with morphometric data, but this can also be done using diffusion or more advanced techniques like diffusion imaging. Here, where the colleagues looked at the fractional anisotropy, or here it was the radial diffusivity in different parts of the median nerve in patients with the anterior interossseous anterior nerve neuropathy. So if we look at the neurophysiological data or information we get from standard electrophysiological techniques as are used in a clinical routine, we usually assess the compound muscle action potential or the sensory nerve action potential. We measure the amplitude, the area, and also the onset. And if we recall that looking at the nerve conduction, or when we assess the nerve conduction velocity using electrophysiology, we actually assess only the fastest conducting nerve fibers. If we look at the histogram of a peripheral nerve, depending the diameter of the different axons, a histogram of the diameter of the different axons of different segments, you clearly see that there is a lot of information we are missing if we use classical neurophysiological techniques because we only assess the fastest conducting fibers. So we have to keep in mind that this is a partial functional diagnostic method. Of course, if you use more elaborate techniques, you can get more information on the other types of fibers, but this is not usually done in clinical routine. So here maybe the assessment, the morphological assessment, be it either using aminography or of course a high resolution ultrasound, can give you more information on the rest of the nerve, the integrity of the rest of the nerve fibers. So I really kind of think that the imaging complements and is very helpful, especially when it complements our thorough clinical and neurological exam and the electrophysiology regarding the function and the structures, especially regarding also localization and substructure affection. And this can give hints to of course, the etiology and the treatment. So the strengths are, we have a high resolution morphological imaging using aminography. We can image the spinal root to the tip of the toe. So we can also look at the proximal nerve segments that are not quite accessible with neurophysiological techniques or nerve ultrasound. We can have a longitudinal assessment. We can look at it qualitatively, but we can also look at it quantitatively. And we can visualize the whole motor unit, so the nerve and the muscle. The weaknesses, of course, as we have seen, there are still discrepancy between the morphological versus the functional aspects. The aminography, if we use just the imaging, is a snapshot, depending on the acquisition parameters you choose. So it's only a snapshot of the disease process. And the experience is still limited. And the significance is also unknown. The normative values are rare. And there's also limited correlation to function and EDX and electrophysiology. Initially, it was only in the hand of radiologists, but now more neurologists and neuroradiologists get or see the potential and start to work together to tailor such protocols. And of course, the weakness is that it is still, there's quite some expert knowledge necessary regarding the acquisition, especially in the interpretation. And it is not cheap, of course. And we have new challenges because it gives us new insights into the pathology of neuromuscular diseases. So with that, I thank you for your attention, and I'm happy to try to answer any questions.
Thank you, Olivier. Very nice presentation. I don't have any questions written, but I have unmuted all of you. So if you go ahead and click on the button, you will be able to talk. Does anyone want to put a question? I will probably start, and hopefully that will encourage others to do it. So I'm going to share my screen again, and I'm going to do the usual devil's advocate question that you always have in this case. So this is a recent paper on the expert opinion and review of the literature about indications for neuromuscular ultrasounds, which is something that people are probably more acquainted with. And it says that in nerve disorders, you get, these are bars that indicate the opinion of those specialists regarding muscle disorders that we'll skip. nerve disorders when they are regional and or multifocal. So the longer the bar, it means the more are interested in. So the black bar means that people would start by doing ultrasound, and the gray bar, would use the black bar means that people would use ultrasound in the assessment, and the gray bar means that they would start by ultrasound, and nerve tumors, traumas and torsions are very well represented. And interestingly, they also use it for brachial plexopathy. And these are focal disorders, so the entrapments and things like that, which were probably one of the first applications of the ultrasound associated with the EMG, and then the polyneuropathies, where CIDP and ALS are the most represented. I'm showing this just to tease you with asking why should we switch to MR neurography, and in which of these entities do you think that MR neurography would bring more added value when compared with echography, ultrasounds?
Thank you. It's, of course, always the teasing question. I don't think I mean, I didn't talk about, of course, about nerve ultrasound. Nerve ultrasound has a huge advantages also, and is a quite available technique where we can have it on bedside. It is also in hands of neurologists, and we can assess with similar and even higher detail the peripheral nerves. But still, the limitations, I think, are the more deeply located nerves, especially in the lower extremities, and especially also in the lower in the lumbar sacral plexus. So this is clearly where the indication of MR neurography is, in my opinion, much is more or better indicated. I think let's say the usefulness also comes with time, because there's much evidence, and we know of the sensitivity and the specificity regarding different diseases. And as ultrasound is much more widely used, we are much more certain about when we can use, or to what extent we can believe what we see in ultrasound compared with MR neurography. So this is actually a problem, because it is quite a new technique, and the systematic approaches have only started in the last 10 years. What I prefer in MR neurography is that the MR signal underlies physical processes, and you can, depending on how you tailor the sequence, you can assess different aspects of this. For instance, look at the diffusion process of protons within nerves. You can look at magnetization transfer, which then correlates also to the myelin integrity. So this is the MR neurography has the ability to go beyond just the morphological analysis. But still, it is very challenging to do it.
Okay, anyone has questions? Anna Costera, I see you there. you can click and ask a question. Don't you want to chip in?
Yeah, I'm there. Congratulations on a very nice presentation. We use MR neurography more frequently for CIDP. We don't really use it for entrapments. And I would like you to comment on the morphometry, because this is a tool that seems to be also useful, possibly as a biomarker if we follow up the patients longer. What is your view on this?
Well, thank you for this question. I do think that the quantitative aspects are a strength that will especially become more and more interesting in the future as biomarkers, as we are, I mean, there are also in muscle diseases, in myopathies, for the different treatments, we try to find biomarkers to have a disease monitoring, and I think especially for also for CIDP, because there are treatments available, and sometimes the clinical assessments or neurophysiological assessments are not completely evident or clear. Additional biomarkers could be interesting, but I clearly see the difficulty that the knowledge on the technique, especially on the quantitative techniques, will still be for a couple of years very limited to specialist centers.
There's a paper on quantitative MR for SMA from 2019, as you know. Do you know of any ongoing trials using MR neurography?
No, not that I'm aware of.
Okay. Any more questions?
I mean, regarding this, a comment is that the methodological approaches are still not clearly defined, and there are no consensus on that. It's not, we're about 10 years behind the muscle imaging.
Okay, so if there are no more questions, I will just thank you very much, Olivier Scheidegger, for your wonderful participation. I thank all the attendants for being patient and being present, but I think they took a lot to take home, and this was a very informative, at least for me, session. When you switch off from the Zoom, you will be invited to fill a survey, and if you do it, we'll return you a certificate of attendance in case you want one. So thank you very much, and goodbye. We'll see you soon. Bye now.